Well, good morning. Thank you so much. That was wonderful. And I'm grateful to everybody who's spoken so far in this conference. I've learned a lot, and I've been sort of re-energized for the work ahead. And I don't know if Nina is still here, but yesterday she talked about the importance of being who you are and doing what you can and listening. And I'm grateful to be included in this group. We've been talking about inclusion and exclusion. I'm not a Latina, but I find that it's very important as we continue all these conversations and work to remember that integration and exclusion goes in both directions. And so I'm glad to be included in this group, and on behalf of all of those who are excluded from the care that they so deserve as human beings. And that's how I see myself really on this Good Friday, as just a member of the image of God that's shared around the world. And so it doesn't really matter to me what somebody's race and ethnicity is in terms of their value, but it sure does matter in terms of their health outcomes in this world in which we live. So my talk right now is pretty much around those who are not even included among, when we say Hispanic or Latino, when we're looking at statistics around the country. And we had pre-conference calls, and I so appreciate what you put together. The last minute, our original conference call was around chronic disease, and we had some statistics that were shared by our speaker who couldn't come, and he was talking about like cancer rates and things. And I was saying, well, those aren't the cancer rates in the community I serve. And we were talking about the differences in terms of having subpopulations, and not even in this whole Latino health conference and this whole thing about diversity is remembering that there is so much diversity within categories as well. And so we don't want to stereotype and say all Hispanics or Latinos or this or that, and to really recognize those who are most vulnerable, who are marginalized, and who are excluded even from their fellow Latino communities. So that's the population I'm speaking about. And we call them at MCN, Migrant Clinicians Network. We kind of refer to folks as the mobile poor more than we say migrant, because migrant's such a pejorative word. We do and historically did focus on the seasonal and migrant agricultural worker, and that's still our core. But we know that a huge number of people experience very similar problems, and they're mobile, and they're poor, and they're mostly Latino as well. So we expand our categories. Basically, we talk about the 3 Ds, that these are the people in our country who do dirty, demanding, and dangerous work. And that puts them at enormous risk. They are the people who die most frequently in occupations, whether it's construction or farm work. They do have the number one cause, the number one group dying at the workplace are Latino. Mining is always competitive with agricultural work in terms of danger and death. And it just depends whether there's a big mine disaster, whether that year mining will outpace agriculture. But typically, consistently, agriculture is the most dangerous occupation in the US, and consistently, those who die most frequently are young Latinos. The group, when we think about chronic disease, we're not just thinking about undocumented, as we've been talking about, but we're talking about even interstate mobility. You know, your slide on North Carolina, 2007, that's great. 2014, they're not paying for pregnant women with emergency Medicaid except for their birth. So they're not doing prenatal care anymore. So if you're pregnant and you're traveling around our country because you're poor and you're an immigrant, you may or may not be able to continue your prenatal care as you change states because of the changes in Medicaid across states. So the whole interstate mobility is an issue, as well as the transnational. We've mentioned several times about the mixed immigration status, which is huge. You had the slide of the 5 million children. There's about 5 million US citizen children born in our country right now who have mixed status households, and it absolutely impacts their ability to get care, even though they're citizens. And then when we talk about the mobile poor, again, the migrant agricultural worker is the largest subgroup. And the thing they all have in common is poverty. This is such a cool slide. It's a slide of human migration around the world. And so it's a pictorial of we talked about globalization a little bit yesterday. So that's a global migration. That's 75% of human migration from 2005 to 2010, and I hope you guys can get these slides afterwards. And what you want to notice, it's all by color, which makes it so easy. So if you go up to the top, the red, North America, and then you look at the yellow, Latin America, you see those huge big wedges. So the biggest migration in the world is the Latin America, North America migration. And then you look at North America and you look at the United States and you see all the many different colors that are coming, okay? Because the United States is red. So the only people leaving the United States would be the red lines. So if you want to quickly, oh, and I'm not good with lasers and I have both hands full. So if you look at the red lines going from North America, they're going over to Europe, okay, for the most part. A little bit to West Asia, but for the most part to Europe. Not all that much. But if you look at who's coming to North America, all the different colors are represented, right? And that's been our history. But the huge, huge, huge migration back and forth that's two-way is Latin America, North America, and it's some of the largest in the world, other than looking at India and some of the migration from India. So we've been talking about Latinos for the last 2 days, and we've been talking about health. We haven't said too much using the word inequity, but we've sort of been talking about it. And I want to talk about health inequity in a Latino grouping in the U.S. who really are a world apart from the typical U.S. experience of any kind. And again, so I wish Luis was still in here because the people who work with these folks are also a world apart. There's inequity at every single level. And you heard my really nice introduction from Leo, and I'm grateful for that. I have been faculty at a university, and when they went over looking to decide what my status was going to be, they said, well, you haven't really had any NIH grants, and you haven't really done any you don't have as many peer-reviewed journal articles as we might like, and your scientific articles, there's not that many, but I had pages of migrant health kind of stuff, and it was like, well, we're not sure that we really need to, we're not sure that we would include that towards your expertise because you're not a subspecialist, you're a generalist. And I said, no, I am absolutely a specialist. I'm a specialist in migrant health. I'm a pediatrician, I'm a specialist in migrant health, and I know more about it than any of you sitting in the room, not in this room, but in that academic room. And I was, this one fellow just kind of looked at me, and he had all the right credentials for the University Medical School. We did our fellowships together, okay? So he had as much training as I had. Got an MPH together at Chapel Hill, but he just looked at me like I was crazy. And I was able to fight them on that and not be hired as an assistant. Well, actually, they were going to start out as like a clinical something professor, and then it was assistant professor, and then it became associate. But, there was such a dismissal of the work and the expertise that I had because it was program-oriented instead of NIH research grant-oriented, and because people kept saying over and over and over again, well, there's not much data on that group. So you can't really do research on that group because, look, there's hardly any data on it. So I did my master's in public health thesis on the health status of migrant children, even though the dean said, you're not going to be able to do that. There's not enough data. It's like, really? Well, we talk about rural health, there's data on rural health. We talk about pediatrics, there's data on pediatrics. So I went and I found all the data that I could on all of the other subgroups that can make a picture, and that's what we had to do, and it got honors and all of that, so went just well, but it's been an uphill fight. So the world apart it's a world apart for me too, and I am grateful to be here because those of us who work in this area are marginalized. So we're marginalized as physicians. I can't tell you how many times people asked me when I was working in the clinic, how long are you there for? Like I was in jail. How long are you there for? It's like, I don't know, my whole life, you know, it's like, why? Because you make less. You're seen as either you're not as good or you have to be there to pay back a loan. That's how you're viewed often, okay? Rather than the very best of the best need to be working with the biggest problems in our society. So we should have the smartest, most capable, most political, most well-spoken people working in this area because it's the biggest problems with the biggest needs, and that's what they deserve as human beings. So health inequity, the World Health Organization defines it as avoidable inequalities, and that's enough. That's all we really need to know, right? It's avoidable both within countries and between countries. And reducing the health inequities is an ethical imperative, moral imperative, use whatever language you want. It's a human rights issue. So these are my people. These are the people that I love. This family happens to be in Idaho, and doing the onions. You notice children in the field because children go with their parents to the field. They work from a very young age, or they are just there because there's no daycare and there's no other place for them to be. And they're exposed to all the things that their parents are exposed to, whether it's pesticides, heat stress, dehydration, assault, any of the other things. So this is the group that I've worked with for all these years, and this is who I think about when I look at these topics. For the purposes of CMAR and the federally funded health centers that we've heard about, there's categorical definitions. The definitions, of course, are made by Congress. So they're only important in that they include and exclude certain people from care. So when we talk about undocumented, if you go to a health center in America, nobody asks you, or they shouldn't, what your documentation status is. They shouldn't ask for a Social Security card in order to get you a medical record. Some places do, but they really shouldn't. They will see you no matter what your status is. But that doesn't mean that they can get you to specialty care, or that they can get you dialysis, or that they can get you the other things, but they will see you. And I'm probably to a health center, they're glad to see you, other than the fact that they're still strapped with reimbursement too. And contrary to what a lot of people think, health centers don't have enough money to see everybody via federal funds to take care of everybody for free. They get a portion of their funds to take care of folks. So when you have somebody who can't pay, yes, you have a sliding fee, but it still costs your health center, and it's still really, really difficult to do. So that's important. But anyway, back in 1962, John F. Kennedy signed the Migrant Health Act, and he started the ball rolling on recognizing these horrible inequities in care. And The Harvest of Shame came out by Murrow, you know, our famous Washington Edward R. Murrow, and on Thanksgiving. And so that was our first health center, actually was a migrant health center, not a community health center. And the community health centers patterned themselves after the migrant health centers, and then they all got consolidated together later. So who are these folks? The numbers vary all the time, and again, people aren't counted all that well, but the official count is somewhere between 1 and 2.5 million workers, okay? And then their dependents, their families. About 500,000 of the workers are children, and there's probably more than that. They only count them when they're 14 and up, and we know that the average age is 11, and often it's younger than that when they're working. What you may not know, and what you can do as advocates, is that there are exclusions in the Fair Labor Standards Act that came out way back at the turn of the 20th century that excluded agriculture from all of the fair labor standards. So children can work in dangerous occupations if that occupation is agriculture. They can't work in any other dangerous occupation. They can work long hours, even during school, if they work in agriculture. So there is revisions of the Fair Labor Standard Act that are coming out, and if you go on our website, you can sign us up as wanting the revisions to happen. They haven't happened for so many years, and the workplace protection standards, it's been 20 years trying to get them to change. So that's something that you can actually do and feel good about even today to make a difference. It's a very young population, so half of the workers are between 20 and 34. Most of them are Spanish speaking. The vast majority are from Mexico and Central America, and 41% didn't have any health care visit at all in the last 2 years. And actually, we only know some of these numbers because of 2 big data sets, and so they're not quite as good as they could be, but they're very consistent. Ever since I started, almost 30 years ago as an outreach worker, well, it was 30 years ago, we've talked about poverty, and the poverty hasn't changed. And, you know, there was poverty in 1962 and 92 and 2012, and there's still poverty. And I'm getting old, and I would like to see these numbers change, but they really haven't changed much. Most of the population has very low literacy. Often it's well below 8th grade. It's more like 5th grade and 3rd grade, particularly for the women. And there's a growing indigenous population, which I'll talk about. These are some girls in Eastern Washington, and they were living in migrant housing. And you can see right behind them the irrigation in the fields. And guess what? I saw that day and was exposed to also was a plane delivering some chemical, flying, I'm assuming like pesticides, but flying, you know, over the fields. And so the drift comes to them. So there's a lot that we don't know about exposure in childhood. And as I said, they're part of the workforce. And we know that they not only go to the work site, but they also live in a dangerous setting. So the farm workers are found in every state, migrant farm workers, but these are the 10 top ones. So California, most of you would guess, Florida, Washington, Texas. So remember we were talking about dialysis. Well, there's 2 of the 4 that don't take undocumented folks. And about half of these folks are considered undocumented. I did all my clinical work in number 6, North Carolina. But folks move around. And so typically the pattern tends to be that families go to 2 or 3 different places, and they know those places, and they come from the same village. So they know like the whole group that they're with and go if they're with families. If they're single men traveling, they can be more nomadic, just looking for work. But typically the families do travel in cyclical patterns together. Indigenous Mexicans are a very discriminated against group, both by their fellow companions from Mexico and also from others. They're not even recognized as indigenous a lot of times, and it's a sad case, but I gave a story at another conference on a little boy who had a ruptured appendix and almost died twice, and I don't know if he's still alive, but all through his hospitalization, the hospital workers didn't understand that the mother didn't speak Spanish. She didn't speak English, she didn't speak Spanish. She spoke an indigenous language, and so she didn't understand anything that they were saying and didn't get the proper care at all. But they're in the western regions, we have a large number of indigenous folks, somewhere close to probably 750,000 in the U.S., and mostly concentrated in the West Coast. We do have a lot of indigenous folks in Washington State who are berry pickers, and I know some of you talked about the Skagit Valley labor movement, and a lot of those families are indigenous families. But they are very discriminated against. And if you haven't read the book called Fresh Fruit, Broken Bodies by Seth Holmes, it's an awesome book. It just came out this past year. And he traveled, he's a PhD, MD, nice guy, traveled with the families all the way down into southern Mexico and worked with them and lived with them for about 6 months doing his PhD on how these families are treated and how they're institutionally, stereotypically discriminated against with racism. So what are the barriers to chronic care? They're huge, but for the population that we see, they either are underinsured or they're uninsurable. We've talked about that a lot, and ACA isn't making a difference there. Their mobility changes their eligibility all the time, like the pregnant woman example I gave and the dialysis examples. The US doesn't have good record systems. Even with our electronic records, we don't even communicate with each other in the same zip code half the time. And we sure don't communicate with each other across the country, and shame on the CDC. Our immunization registry isn't national, it's local. So we don't have good records. Language, literacy, and culture. And I want to say something here, and I hope it won't be offensive, but I worked with this population in North Carolina, and I took Spanish when I was a kid because my mother spoke French and grew up in a French-speaking household, and I was rebelling. So I took Spanish. And so I learned some Spanish, not a lot. And then my patients taught me lots and lots and lots of medical Spanish. So my medical Spanish with my patients was really pretty good. Then I had a medical student come and train with me who was very well educated and was from another Spanish-speaking country. And he corrected all my Spanish, and I was glad because I had no idea whether what I was saying was good or bad. I just said what people seemed to be happy with. And I knew that it was bad. I knew my Spanish was bad. So my Spanish got much better after he was with me. And then my patients said, "What happened to your Spanish?" And I said, "Oh, I've gotten trained. And you were better before. Like, go back to your Spanish." And it was because I was just talking like they were talking, right? Or worse, right? So I was more accessible as trying to be who I was and learning from them, right? So it's just the point is they thought it was kind of snooty, my Spanish. And it wasn't the kind of Spanish they spoke. And so that whole idea of culture, it has so many levels and variations to it, and it has been my experience that just because I'm pink people don't necessarily want to see me. And just because somebody else is brown, it doesn't mean that any old brown provider is the right one for them. So we just have to be careful about our stereotyping there too. And that's where trust goes. The chronic conditions are huge. We hear about obesity and diabetes all the time, but obesity isn't because they're sitting around watching TV, just eating lots of food because they have lots of money to spend on food. The mobile poor, how many of you would very quickly know what percentage of your income you spend on food? Raise your hand real fast. How many of you would know that really fast? Okay, not many of you. So think about your monthly income or weekly, whichever's easier for you, and then take 10% of it. And then think, is that reasonable or not? 10% is about what folks are expected to spend on food, okay? If you're really rich, you might spend less than that. Our population spends 50% of their income on food. Why? Because they just like spending money on food? No, because they make so little money. So 50% of it goes just for food, and it's poor quality food, but it's filling. And if you look at how people eat, there's very good data that shows poor people eat food because it's filling. It's quantity, okay? It's filling. So they buy food that is filling. Quantity matters. Middle income people buy food and like food because it's quality, it's nutritious, and it tastes good. Rich people have food because of the presentation and uniqueness. And that's well documented, okay? So when we're working on obesity and food and food security and all of that sort of thing, we need to remember that it's not, you have to remember where people are. So you want them to move towards the quality part? Well, we have to do a lot of work around food availability and affordability. So again, this is a big issue with me. It's one of my huge heart issues is how hungry these people are who pick our food. And it's, so if you want to talk about injustice, there you go. So they're, even among people in poverty, farm worker children are 50% more likely than other children in poverty to be food insecure in that wonderful state of Georgia. In North Carolina, my state, farm worker families were 4 times more likely to be food insecure than the general population, and twice as likely than the poor population. And when you talk about, somebody asked me, well, what does it mean to be food insecure? Okay, food insecurity means that you cannot get the food that you want to feed your family through traditional means of buying the food, so that you have to either scavenge, steal, or go to supportive means like shelters and that kind of thing, okay? So that's what food insecurity is. So this person said to me, so, well, like, what does it mean when you say that they're hungry, when you say that 80% of the kids are hungry? Like, how hungry are they? And I said, well, they're hungry enough that their bodies are showing 80% of them have vitamin deficiencies and that they're stunting in their growth. And there's an article in your resource thing that shows the stunting in migrant children because of their anemia and their food insecurity. And despite being on WIC, all of them qualify, they still have high rates of anemia. So that's just an injustice. And I'm just about done. The other thing that there's very little, there's more research and it's growing and it's good here in Washington State and in the WWAMI region, but once again, it doesn't get the recognition at the university levels often that it should, University of Washington being an exception to that, because when we talk about pesticide exposures and that sort of thing, people are always saying, it's anecdotal. And it's really hard for a busy clinician to say, when they get somebody who comes in with itching eyes and they're not enough spit in their mouth. I used to get that all the time, and I thought, that's just bizarre. Then I started learning about pesticide illness. When they have a chronic pesticide exposure, there's not, like, what do you tell them? Okay, don't work. Well, that's not going to work. And there's no recourse in most of the states. And again, our states also vary not just by Medicaid, but by reportable pesticide reporting. And the West is more aggressive than the East and the South, not surprisingly. So in more states than not, there's very little reporting of pesticide occupational exposures, okay? So we actually don't even know how many people are really exposed, and this would be a great research area to find out more, but only if you're going to do something about it, right? Because I can tell you that everybody's exposed. So, like, let's do something about our research results. Occupational mortality, I mentioned that, but heat-related mortality is 20 times higher than any other occupation, including construction and other outdoor occupations. Foreign-born Hispanics have the highest rate of fatal injuries, and the highest fatality rates are in new immigrant areas. So they're not trained. You know, people don't know what to do. They don't know how to call 911. They don't want to leave the work site if they're sick. They want to keep working because they don't want to be fired or let go. There's all sorts of issues that we've seen, and I have anecdotes of mothers, a 17-year-old giving birth by herself in a migrant camp while everybody was at work because she didn't know what to do. And pesticide exposures and on and on. So lots to look at. What do we know? As I said, you know, we can figure things out. Even though we don't have fantastic data, we can figure some things out. We do know that there's later diagnosis of cancer and higher rates. We do know that Mexican adults in the United States who were immigrants have the highest non-immunization rates in our country of adults. A fellow at the CDC shared that with me in December, and that will be published by the CDC. We do know about the obesity and food security data, diabetes, hypertension. We've heard some of that. There is good pesticide data out there. There's more and more concern around all the babies with birth defects in Yakima, et cetera, that is pesticide related. And there have been some studies around air quality and asthma, stress, and PTSD. So real fast, what we do know in our National Health Center data, and I looked at Region 10 for this, and it's accessible on the website. You can look it up, that in our population that I looked at, the clinics particularly that served migrant farm workers or who had huge Latino populations, so that the majority of their patients would be that. The cervical cancer screening rate was 50 to 60%. The guy that was going to talk was saying that that cervical cancer screening isn't a big problem in Latinas because it's about 90%. And I was like, not in our population. So again, there's within the big Latino population, there's subpopulations. And the colorectal screening rate at best is 10 to 20%. Hypertension was about the same rate as in other places. Diabetes was really not much higher than expected. And then the asthma rates were pretty low, except in Yakima, which is, again, interesting. And then we talked about this yesterday, stress and PTSD. So how do we even define it? What language do we use? How do we approach it? But there has been good data showing that in migrating undocumented women, about 60% of them experience some sort of assault, either before, during, or after migration. And their children witness it too. Sometimes their children experience it. And so there is lots of PTSD and stress and depression. What we don't know are things that makes me furious that we don't know, since we've had a act since 1962. We don't know things like, what's the average life expectancy of a migrant farm worker? Somebody said 47 to Congress back in the 60s, and that got put down like gold, and it was just out of the top of their head. That's not true. But we don't actually know how long they live. We don't know how many are disabled. We don't know how many live with chronic pain. We don't know what people do after they stop doing farm work. We don't know their birth defect rates. We don't know infant mortality rates. You can see there's a lot that we don't know. So there's lots that you can study. And I've talked about most of it, and my time is up. So here are all your possibilities. Go back to that.
So we have a little bit of time for any conversation about either presentation from Rudy or from Jenny. Yes.
For Jenny, so all those statistics that you were just showing, are those pertaining to partnership communities? I was interested in the, you had a statistic in there about, you said that foreign-born, excuse me, you said that foreign-born Latinos have the highest rate of, I think it was, occupational accident mortality.
Yeah.
So is that just in farm worker communities, or is that across?
No, it's across the board.
So that would be as true probably like here in Seattle. Okay.
Construction. I mean, again, it's usually the 3 Ds: the dirty, dangerous, and demanding. Thank you.
And are there any kind of health education, prevention programs, anything that addresses some of these issues such as obesity? I'm also just really astounded that, we've been paying, some of us have been paying attention to farm worker issues at least since the 1960s, and yet it seems like the situation is just as messed up as it was then, and I don't know what to say. It's just astounding.
So sad. And that's where I said to somebody, like, if I do nothing else from being here. I hope that the new generation that's here will have some sort of revolution, civil rights work that happens that looks like what happened in the 60s, because this little incremental thing is not working. And I'm too old to do it. Yes, things are happening around. A number of people are working on food security, and they're working at it from the idea of local sustainable gardens and that kind of thing, which again, when you're mobile and you don't own land, you don't own anything that you can take with you, is difficult, but there are some community garden kind of activities going on. And there's also some work that's going on with grocers. And that was actually an executive at Whole Foods asked me the question about how I knew whether they were hungry, like how hungry are they? And there are some little models, but like often happens, because it doesn't qualify as real research, there's programs, then it doesn't get published because you try to give it to a peer-reviewed journal and they don't take it because it's a story more than it's the data in the form that they want. So that's where you people who are real research need to partner with measuring outcomes, because there's all kinds of good work happening, but it's not measured in a way that can be reported and published, right? And that's been true for years. So yeah, there's work that's going on, but like school lunch, all these kids qualify universally. A migrant child qualifies for school lunch, school food. But when school's out, unless there's somebody who's picking up that program, then they don't get anything. So there's lots of gaps, both at the policy level and at the program level. I don't know if that answers.
Good morning. My name is Mary Jo Ibarra Vega. I just wanted to make a comment, regardless of the, for the first speaker about AEMs and getting people who have that will be covered for kidney dialysis with Affordable Health Care Act. As an in-person assister, I have patients who need dialysis, who went through the Affordable Health Care Act, who took them to the Washington Health Plan Finder, who then get sent to DSHS for them to get approval, get stuck, gets lost, are waiting, and in the meantime, our patients can die. And because dialysis centers are set up and getting money from who knows where, people are getting treated so they won't die while they're waiting to be approved. So while the Affordable Health Care Act is great and wonderful in some situations, the system still continues to not be wonderful for this person who comes in every day. Have we heard anything? Have we heard anything? Have we heard anything? And then for me, just the stress of, oh my gosh, she needs to be treated. I'm calling, I'm checking. I mean, we're doing everything possible. So whether our state can afford that and does that, there are systems that are being stuck, and people can die if we're not. Some of us who are advocates helping them, because there are people who don't know how to do that. People will die.
Yeah.
And so it's just more advocacy, and getting on those people who are doing it. It's really disheartening to me as somebody who really feels I can do things, but there's some situations that we're just waiting, we're waiting. So I just wanted to make that comment.
Thank you.
We were focused on the end stage of this disease process. So you're starting with a bunch of healthy people, pre-diabetics, diabetics, and then at the end is this. What percentage of the end stage renal disease could be prevented if people got prompt treatment, prompt diagnosis and continuous treatment for their diabetes or their hypertension?
It's hard to know because it is hard to study, right? It's a 20-year process. But we do know that earlier you treat, it almost, studies have shown that even if you treat people very early on, like if you look at the study on diabetes that was done in the United Kingdom, the UK PBS study, they treated very early when people just started having protein in the urine. And that made a big difference where it didn't even matter whether you used ACE inhibitors or other drugs. As long as you treated the diabetes and the hypertension early on, people just, the progression stopped. So the earlier is always going to be better. The study I showed about, how ACE inhibitors work well, that's really too late. That's the only time those drugs really work are when people already have lost almost half their kidney function. And what it's doing is it's slowing things from going from a loss of about 10% of your kidney function a year down to about 4% a year, but people still kind of will end up on dialysis. So the message is always going to be the earlier the better in the treatment of diabetes and the hypertension.
I wanted to make a comment. I don't want it to be very negative, but I wanted to thank Ruby and Jenny to talking about undocumented or illegal, because the fact that these people is dying is we're talking about inclusion, representation, but either the government doesn't want to talk about them. And and we can eat
healthy, we can have a fresh fruit, while those people is in the back of our yard, and we deny. And I always spoke, and this is our mission, for those people. We have to change that, and we have to say basta ya, because they are in the border, and this has happened from American time now, happened before with Vietnamese, Cambodia, Sweden. Now it's with Latino. Tomorrow will be with another. But I believe everybody has a responsibility to do something, and all the patients that Ruby have getting to have this because they didn't have prevention. It's ridiculous that in a country like America, diabetes people get it to have kidney problem, and something like that. But thank you to both of you to talking freely about this issue that is undenied, for many of us.
Okay, well, we have breakout sessions, and then we'll reconvene and lunch. But there's some details. Hold on.
Yeah.
Megan was going to fill us in.
So we're going to break for 10 minutes. There's coffee in the lounge, and then you're going to go to your breakout sessions, like Leo was saying. And then you're going to meet back here for